Okay, in our video series of rheumatology lectures, in this video, we are going to talk about systemic sclerosis. We are going to discuss that what is systemic sclerosis, also called as scleroderma. We are going to discuss the presentation, the clinical features, the causes, as well as we'll discuss how do you diagnose systemic sclerosis and the treatment of systemic sclerosis in detail. A 48-year-old lady comes to your clinic and tells you, the doctor, for the last few years, I have been feeling that my skin of the hands is tightening. The skin of my face is also getting more tight. I feel like that I cannot use my hands properly. I cannot articulate the movements properly because I feel like the skin in my hands is getting more thick. There is waxy, shiny appearance of my skin, leather-like appearance of my skin. I cannot open the mouth properly. I feel that it is too tight. There is abnormal loss of the wrinkles of the face. Even the nasolabial folds are lost. Doctor, whenever I try to drink water or try to eat food, there is dysphagia. I cannot eat food properly. I cannot swallow food properly. I feel like that each bolus is stuck in my esophagus. Whenever I am exposed to cold water or to cold weather, the color of my hands changes. Raynaud's phenomena, the fingers get painful. This is a classical presentation of scleroderma, also called as systemic sclerosis. How does it happen and what is systemic sclerosis? Today we are going to discuss that. Systemic sclerosis is a chronic connective tissue disease of unknown cause that affects the skin and subcutaneous tissues. There is abnormal collagen deposition in the skin that results in skin tightening. There is abnormal collagen deposition in the face that results in the loss of wrinkles and tightening of the skin. Patient feels like that there is a waxy appearance of the skin, leather-like skin. There is abnormal deposition of this collagen and fibrosis in the esophagus, resulting in dysphagia. There is abnormal deposition of the collagen in the internal organ, the vital organs like heart, lungs, and kidneys, resulting in renal failure, resulting in heart failure, resulting in pulmonary failure. This is systemic sclerosis. It is more common in females as compared to males, 5:1, and peak incidence in middle-aged females, 30 to 50 years of age. As all other rheumatological diseases, middle-aged females are the main target of these autoimmune diseases. The pathophysiology is autoimmunologic phenomena, that there is autoimmune stimulation of these fibroblasts that result in abnormal collagen deposition and fibrosis in the skin and the internal organs. There is inflammatory synthesis of extracellular matrix. The fibroblast proliferate abnormally and there is increased synthesis of normal collagen leading to fibrosis. There is abnormal collagen synthesis, increased synthesis of the collagen that leads to fibrosis, and that fibrosis results in thickening and tightening of the skin. Non-inflammatory vasculopathy, the vessels are also a target of this abnormal proliferation of the collagen that results in all the clinical features that you see in patients with scleroderma. Systemic sclerosis is divided into two categories: limited systemic sclerosis and diffuse systemic sclerosis. In limited systemic sclerosis, it's mainly the skin that is involved. All the presentation are usually in the skin. And it's quite an obvious diagnosis when you see these patients with CREST syndrome. What is CREST syndrome? We'll discuss that in detail. There is, in limited systemic sclerosis, there are skin involvement and skin features. In diffuse systemic sclerosis, there is internal organ involvement. And when the internal organs are involved, like lungs, kidneys, and heart, the disease is life-threatening. This is a deadly disease. Now, what is the difference between limited systemic sclerosis and diffuse systemic sclerosis? In limited systemic sclerosis, as I said, that there is major involvement of the skin. Usually the overlap also exists in some percentage of patients. The difference might not be as clear. Usually these cutaneous involvement patient ultimately get the organ involvement, and the patients with organ involvement get the cutaneous symptoms as well. So there is always an overlap. But the major two categories are limited and diffuse. In limited, neck, face and the distal limbs, the hands are commonly involved. In the diffuse, the skin of the trunk and extremities and the face are mainly involved. But the major involvement of the skin is seen in limited systemic sclerosis, not in the diffuse one. But even if the skin is involved, it will involve the trunk mainly. Extracutaneous manifestations like the damage to the organs is rare in limited systemic sclerosis, but it can happen. In diffuse, the extracutaneous manifestations, the organ involvement is the major part in diffuse systemic sclerosis. Sclerodermal renal crisis is an emergency. Cardiac involvement, interstitial lung disease, pulmonary artery hypertension. This is how the diffuse scleroderma damages the vital organs of the body. The onset of systemic symptoms is slow. Usually the patients with limited systemic sclerosis, systemic sclerosis with cutaneous involvement get organ involvement after 10 to 20 years. After 10 to 20 years of the Raynaud's phenomena, usually it is compared with the Raynaud phenomena, that if the patient of limited systemic sclerosis has the Raynaud phenomena, the skin manifestation, after 10 to 20 years of the appearance of Raynaud's phenomena, these patients get organ involvement. And in diffuse, organ involvement is the main thing. The organ involvement is rapid within weeks. Limited systemic sclerosis is also called as CREST Syndrome. CREST Syndrome is basically a mnemonic for all the manifestations of the disease. Now we will go into detail in the limited systemic sclerosis and what is CREST Syndrome. CREST Syndrome has calcinosis. Calcinosis is abnormal calcium deposition in the skin. There is abnormal calcium deposition and there are small nodules of calcium deposition that takes place in the skin. That is called as calcinosis. And when you perform the serum calcium levels, serum phosphate levels, everything is normal. Despite having a normal calcium level in blood, normal phosphate level in blood, these patients have deposition of calcium in the skin. That is due to abnormal inflammatory process that is going on in the skin. Raynaud's phenomena. These patients have Raynaud phenomena whenever they put their hands into cold water or whenever they are exposed to cold. They get severe vasospasm which results in whitening of the skin, and that vasospasm is painful. Then they get reactive vasodilation and then their hands become very red. So spasm of the vessels followed by vasodilation resulting in the red skin. Initially it's blue due to deoxygenation, then it's become very red due to excessive blood flow. That abnormal dysregulation of blood flow results in Raynaud phenomena in this patient, and this Raynaud phenomena is a secondary Raynaud phenomena because it is associated with systemic sclerosis. Raynaud phenomena, the primary Raynaud phenomena, you do not know the cause. Whenever Raynaud phenomena is associated with a disease like SLE, in SLE there was Raynaud's phenomena, that is secondary Raynaud's. And whenever it is associated with systemic sclerosis, that is a secondary Raynaud's. There is esophageal dysmotility. This collagen deposition also occurs in the esophagus, resulting in fibrosis of the esophageal sphincter. And that fibrosis of esophageal sphincter results in dysphagia, because now the esophageal sphincter cannot relax nor it can contract. So there is reflux of acid from that abnormal esophageal sphincter, because that esophageal sphincter is fibrosed, it cannot contract as well as it cannot relax. So it won't let the food pass easily, therefore the food will be stuck in the esophagus and there will be dysphagia. And it will let the acid flow upwards because it does not contract when it has to contract. Therefore there will be acid reflux as well. So both symptoms will be there. On esophageal manometry, there will be no tone of the esophageal sphincter because there is loss of the normal esophageal sphincter tissue. There is fibrosis in the lower esophageal sphincter. Sclerodactyly. Sclerodactyly is the abnormal thickening of the hands of the skin, the shiny, the waxy appearance of the skin. Telangiectasias, abnormal vessel dilations, abnormal spots. You will see abnormal spots, abnormal vessel dilation. That is the vasculopathy that is seen in scleroderma. That is called as telangiectasias. CREST. So in CREST syndrome, you will see calcinosis, Raynaud's phenomena, esophageal dysmotility, sclerodactyly, telangiectasia. So mainly if you see in the cutaneous form, in the limited systemic sclerosis, it's mainly the skin of the hands and the face that is commonly affected, except the esophageal dysmotility. All these clinical features are seen in the face and in the hands. Moving on to the cutaneous involvement of the skin, there is thickening and hardening of the skin. Sclerodactyly, initially edema takes place during the inflammation process, and with that edema fibrosis occurs. Therefore there is waxy appearance, the leather-like appearance. Limited range of movement, as this fibrosis does not let the hand move properly. They cannot open their mouth properly. Digital pitting is seen. Due to fibrosis, there is digital pitting. The skin gets contracted inwards. That is called as digital pitting. In face, you will see mask-like faces because of the loss of the wrinkles. They cannot have the proper smile. They cannot express they do not have proper facial expressions due to the fibrosis of the skin, the thickening of the skin, smoothing of the wrinkles, microstomia, small mouth. This is a picture showing abnormal loss of the nasolabial fold, abnormal loss of the wrinkling, microstomia. And look at the hands. Look at the thickening of the skin, the waxy, shiny appearance of the skin. With this, there is sometimes salt and pepper appearance of the skin as well. Sometimes you will notice that there is depigmentation at the hair follicle level, and that depigmentation appears as salt and pepper skin, especially in the patients with dark complexion. Now, that was all about the limited systemic sclerosis, the cutaneous involvement. After 10 to 20 years, usually these patients with limited systemic sclerosis, they can develop the organ involvement. Or if the patient has diffuse systemic sclerosis, there will be damage to the organs. Now, in diffuse systemic sclerosis, these patients can have sclerodermal renal crisis, where there is damage to the kidneys. Basically what happens is that these patients develop malignant hypertension and they come to your emergency department. In the emergency department, if you receive a patient with scleroderma having malignant hypertension, you must always think of oliguric acute kidney injury, scleroderma renal crisis. The first thing that should come into your mind whenever a patient with scleroderma comes to your emergency department is that this patient is now developing sclerodermal renal crisis, and this malignant hypertension will lead to acute kidney injury, and there will be oliguria, no urine output. It is associated with microangiopathic hemolytic anemia and thrombocytopenia like HUS. We'll come back to the renal crisis in a while when we'll talk about the management. It is treated with ACE inhibitors, and sclerodermal renal crisis can lead to chronic kidney disease. Basically, renal arteries get thick and there is fibrosis of the renal arteries. Therefore, the blood flow to the kidneys is compromised, resulting in increased renin stimulation and hypertension. That is the mechanism that occurs in sclerodermal renal crisis. Pulmonary involvement. Fibrosis, abnormal collagen deposition takes place in lungs, and that results in interstitial lung disease in 80% of the cases. Pulmonary artery hypertension, which is lethal in these patients. These patients on examination, you will see that there will be loud P2. That loud P2 is a signal that this patient has now developed pulmonary artery hypertension. This is because that the arteries in the lungs, pulmonary arteries, they get stiff due to abnormal collagen deposition, and those stiff arteries do not relax properly to the blood pressure. Therefore, those stiff arteries will have blood flow and there will be increased pressure, and these patients will be short of breath. That is a sign. Scleroderma patient developing shortness of breath is a sign that that patient is now developing pulmonary involvement. Cardiovascular involvement. These patients can have a heart failure due to fibrosis in the heart. Pericarditis, myocarditis can develop lethal conditions when the scleroderma involves the heart. In GIT, esophageal dysmotility takes place. Dysphagia, small bowel dysmotility. Therefore, when the small bowel is not moving properly, there will be bloating, constipation, cramps. Now, coming to the diagnosis of systemic sclerosis. In the diagnosis of systemic sclerosis, it's a mainly clinical diagnosis where the clinical presentation, especially if a patient with CREST syndrome or limited systemic sclerosis comes to you, the very complaint that I feel like that my hand skin is tightening and their facial appearance usually is a giveaway for the diagnosis in these patients. In the diffuse, the disease is mainly occult and the skin manifestations help the diagnosis. It is mainly a clinical diagnosis, and the first and the foremost test in all autoimmune diseases is mainly anti-nuclear antibodies. Autoimmune diseases, the first test you go do is anti-nuclear antibodies. If the anti-nuclear antibody is positive, it means that there is some rheumatologic disease present in the body. Maybe it's SLE, maybe it's Sjogren disease, maybe it's Scleroderma, maybe it's rheumatoid arthritis. It can be anything. But if the ANA is positive, it means that you have to look for the proper profile of all the antibodies and you have to find out which autoimmune condition is there. And when you send a proper autoimmune profile for the specific antibodies, you will find out that there will be anti-centromere antibodies positive. There will be anti-SCL70, also called as anti-topoisomerase antibodies, that are positive, that are elevated. Anti-RNA polymerase 3 antibodies. These are the classical antibodies. First two, you should never forget the first two. And sometimes they say that the CREST syndrome specifically has anti-centromere antibodies. In cutaneous or limited systemic sclerosis or in the CREST syndrome, it's the anti-centromere antibodies that is majority of the times positive. So remember the both C's, C for centromere and C for CREST syndrome. But there can be an overlap as well where both the antibodies are positive. In diffuse systemic sclerosis, it's mainly the anti-topoisomerase antibodies, anti-SCL70 antibodies. You should never forget these antibodies. These are very high yield, very important point. So the initial test is always ANA. Then you do the specific antibodies and you find out that this is scleroderma. Do you remember which antibody is the most specific antibody for SLE that we discussed in SLE lecture? If you remember that, please make sure to comment in the comment section. Another thing that is done in these patients is nail fold microscopy. You will see that patients having nail fold microscopy where they look at the nail fold in the microscope and they look at the vessels. Normally the vessels are like this in the nail fold. But in patients with systemic sclerosis where there is vasculopathy, damage to the vessels, you will see that the damage to the vessels will result in extreme widening of the spaces between these vessels. There will be increased gap between these vessels and these vessels will look like as if they have been damaged and destroyed. So this picture shows the normal vessels in the nail fold, then the early change where there is increased widening and space is increasing, then these are fading away, then there are damaged vessels that are present. The increase in gap between each vessel, it means that the vessels is getting damaged. That is nail fold microscopy, and that mainly occurs when the patient is having Raynaud's phenomena. If the patient is having Raynaud's phenomena, go for nail fold microscopy as well. You will find the hint. Now coming to sclerodermal renal crisis, as I said that diffuse systemic sclerosis damages the kidneys. It causes sclerosis of the renal arteries. Whenever there is sclerosis of the renal artery, the blood flow to the kidney is compromised. Whenever the blood flow to the kidney is compromised, kidney thinks that there is hypotension in the body and kidney starts releasing renin in the blood. There is increased renin-angiotensin activation. The renin gets released and results in hypertension. The angiotensin 2 is activated and that results in hypertension. The patients usually would come to you with malignant hypertension in the emergency department, and they will have their or either they will tell you themselves that they are having scleroderma or systemic sclerosis, or they will give you previous record, and in that you will find out that the patient is having systemic sclerosis. Hypertension in a patient with systemic sclerosis, a hypertensive emergency, you should always think of sclerodermal renal crisis. These patients of scleroderma, if they get acute rise in blood pressure, suspect sclerodermal renal crisis, it has high mortality associated with it. Straight away order serum creatinine and urine protein. After some time, these patients will develop oliguria and develop acute kidney injury. So in the meantime, to control this blood pressure, you do not need to give the conventional drugs like labetalol or hydralazine that are prescribed in the emergency department for hypertensive malignant hypertension. For malignant hypertension, the common drugs that are used are nicardipine, labetalol, hydralazine, isocate. These are the drugs that are commonly used to treat hypertension in emergency department. But these drugs are not used in patients with scleroderma, patients with sclerodermal renal crisis. In these patients, you use the ACE inhibitors, you use captopril, you increase the dose of captopril whenever there is no response. 10% reduction in BP every day until the patients get normotensive. You do not suddenly decrease the blood pressure, you slowly and gradually bring the blood pressure down. ACE inhibitor is the treatment. So you must remember sclerodermal renal crisis. To treat hypertension, to treat this renal crisis, you use ACE inhibitors. Now coming to the management of systemic sclerosis. Now for the management, we treat each and every problem individually. We treat the calcinosis, we treat the Raynaud's phenomena, we treat the esophageal dysmotility, we treat with skin, give drugs for the skin tightening. For the Raynaud's phenomena, the first line drug is the calcium channel blocker like nifedipine. Nifedipine is given and it works really well in patients with Raynaud's phenomena because it causes vasodilation and it does not let the vasoconstriction that takes place when the patient is exposed to cold. If there is severe or refractory disease not responsive to nifedipine, then you can add sildenafil. Sildenafil that comes with the name of Viagra. Sildenafil is a vasodilator and it has the same mechanism. That's why it is used in erectile dysfunction. The same mechanism, it causes vasodilation. IV, iloprost, prostaglandin agonists, these cause vasodilation. Coming to the treatment of digital ulceration, the digital ulcers that the patient is getting, you give PDE5 inhibitors, same thing, just like sildenafil, tadalafil, the same family, sildenafil, tadalafil, these all are phosphodiesterase inhibitor and they cause vasodilation. So the abnormal vessels, you cause those vessels to dilate because those are not supplying blood properly, therefore there was abnormal ischemia to the fingers. IV iloprost. Iloprost is prostaglandin agonist. Anything that ends with prost is basically a prostaglandin agonist. If severe or refractory disease, you add bosentan. Bosentan is endothelin receptor antagonist. Endothelin causes vasoconstriction. Bosentan blocks endothelin, results in vasodilation. For cutaneous fibrosis, early diffuse cutaneous fibrosis, phototherapy is used. For mecotherapy, include methotrexate. Remember, important drug for cutaneous fibrosis. Methotrexate, mycophenolate, mofetil. These are all the immunomodulator drugs. These immunomodulator drugs cause the slowing down of the thickening of the skin because of they slow down the immune response, because there was immune system that autoimmune phenomena was resulting in skin thickening and abnormal collagen deposition and proliferation of fibroblast. You stop that with these immunosuppressant drugs. But if there is severe refractory fibrosis, then you use cyclophosphamide, the bigger guns. But do you know it has major side effects? What are the side effects of cyclophosphamide? Cyclophosphamide causes hemorrhagic cystitis because it produces a toxic component, acrolein. Acrolein accumulates in bladder and results in cytotoxicity, damage to the bladder, bleeding from the bladder, hemorrhagic cystitis. How do you treat cyclophosphamide induced hemorrhagic cystitis? You give Mesna, MESNA. Mesna is given for the treatment of the side effect of cyclophosphamide, which is hemorrhagic cystitis. Calcinosis cutis. The calcinosis, the calcium deposition, is treated with carbon dioxide laser. The dermatology people do that. Surgical removal if they are causing pain and symptoms. Also, you tell the patient to have supportive care, avoid hand trauma, because that will result in, during the recovery process, there will be increased fibrosis of the skin. Avoid exposure to cold to prevent the Raynaud's phenomena. Wear gloves when they go outside. Prevent dry skin. Apply warm oil, paraffin bath, emollients on the skin to keep the skin soft. Encourage smoking cessation, because smoking causes vasoconstriction and these patients have Raynaud phenomena. Offer antihistamine if the patient is having itching. Whenever there is increased turnover of the cells, or whenever there is increased collagen deposition, there is release of histamine and that results in itching. So you give antihistamine if the patient is having itching. You avoid beta blockers that can result in vasospasm and worsen the Raynaud phenomena and digital ischemia, as these patients have cardiologic involvement as well. Patients have heart failure, but you avoid beta blockers that can cause vasospasm in the hands. Pulmonary artery hypertension. Pulmonary artery hypertension is the most common cause of death in these patients. Previously, it was the kidneys that was the leading cause of death in these patients. But after the introduction of ACE inhibitors in sclerodermal renal crisis, the mortality by kidney has gone down, but the mortality by lungs is still the leading cause. Now the leading cause of mortality in scleroderma, systemic sclerosis, is the lungs involvement. Pulmonary artery hypertension is even more lethal than interstitial lung disease. Although interstitial lung disease is more common, but pulmonary artery hypertension is more lethal. For pulmonary artery hypertension, you give combination of ambrisentan, which is endothelin receptor antagonist causing vasodilation, tadalafil, which is a phosphodiesterase inhibitor that results in vasodilation. Interstitial lung disease is treated with mycophenolate, mofetil. Mycophenolate is an immunomodulator and suppresses the immune system, resulting in treatment resolution of the interstitial lung disease. Screen all patients for the signs of respiratory distress, as respiratory distress and lung involvement is the common cause, very common cause of death in these patients. If the patient is having GERD, because there is fibrosis and that cannot contract, there will be acid reflux, treat that with PPI. There will be dysmotility, treat it with motility drugs, metoclopramide, that increases the contractility of the intestine. Small intestinal bacterial overgrowth due to abnormal stasis of things in the gut, because the gut is not contracting and pushing the food, there will be abnormal growth, the food will rot and there will be bacterial overgrowth. Therefore, the patients will have an abnormal feeling of bloating and constipation. You treat that with rifaximin. Rifaximin is an antibiotic that kills these bacteria specifically that produces ammonia. Now, it can happen that in your exam, you receive a question, and in that question they tell you that the patient has malar rash and that patient has Raynaud's phenomena and the patient has anti-nuclear body ANA test positive. You will be thinking of SLE, as we discussed all this in SLE. Then they tell you that the patient has proximal muscle weakness as well. Patient cannot move her hands above her head. There is proximal muscle weakness. Cannot reach an overhead cabinet. Cannot comb her hair due to the proximal muscle weakness. The patient CPK level is also elevated. You will be thinking of polymyositis. First of all, you are thinking of SLE, but that patient is also having polymyositis. Then they give you that the patient also has small joint pains and there is sparing of the dips. Now you will be thinking of rheumatoid arthritis. Now what is this patient having? There is SLE feature, there is features from rheumatoid arthritis, there are features from polymyositis. This is mixed connective tissue disease. In mixed connective tissue disease, there is overlap of 3 autoimmune diseases: systemic sclerosis, SLE, and polymyositis. So that's an important point to remember for exams, especially the antibodies that is positive, anti-U1 RNP antibodies is positive and specific for mixed connective tissue disease. If anti-U1 RNP is positive and these features are there, this is a mixed connective disease because these autoimmune causes have an overlap with each other. The treatment is with steroids and immunosuppressant. And like every autoimmune disease, ANA is positive. It is sensitive but not specific. This antibody is specific for mixed connective tissue disease. If you liked my video, please click on the subscribe button and check out my other videos on rheumatology lectures, emergency medicine lectures, and ECG lectures. We discussed what is systemic sclerosis, more common in females, the pathophysiology, the limited form, the diffuse form, the CREST syndrome. Limited form involves the skin, diffuse form involves the organ, the CREST syndrome, calcinosis, Raynaud's phenomena, esophageal dysmotility, sclerodactyly, telangiectasias on skin, the cutaneous involvement, digital pitting, face changes that are seen in face, salt and pepper skin, sclerodermal renal crisis treated with ACE inhibitors, pulmonary involvement, cardiovascular involvement, GI involvement, ANA for the screening and specific antibodies, nail fold microscopy, renal crisis treated with ACE inhibitors, Raynaud phenomena treated with nifedipine, the treatment of digital ulceration, cutaneous fibrosis treated with methotrexate, mycophenolate, calcinosis, cutis, surgery is needed, supportive care, avoid beta blockers if Raynaud phenomena is there, pulmonary artery hypertension treated with bosentan, ambrisentan, tadalafil, screen all patients for respiratory diseases, PPI for GERD, and mixed connective disease where systemic sclerosis, SLE, and polymyositis, all of them are there, and anti-U1 RNP is positive. If you liked my video, please click on the subscribe button and check out my other videos on infectious medicine, rheumatology lectures, and ECG lectures. The link of those videos is given in the description below. Thank you very much. If you liked my video, please click on the subscribe button and check out my other videos on rheumatology lectures, infectious medicine lectures, emergency medicine lectures, ECG lectures. There are a lot of playlists. If you find this channel helpful, you can support us on Buy Me a Coffee. Thank you very much.